to speak about nutrition today and also provide some PEG education. A couple of people here already have PEGs, are well versed in it, a couple people don't. But I always like to take an opportunity to talk about it whenever I get the chance, because there are a lot of things that people think about that aren't necessarily true, and I always like to take the opportunity to clear things up a little bit. I was going to ask Amber to come up here to exact some revenge, but she has escaped us, so I will see her on Monday. So nutrition and ALS. Nutrition is a huge component of everyone in general. No matter what disease you have, no matter what's going on. All of us know how important nutrition is. And in ALS in particular, it is very important. And there are several studies, and we've known for a long time that malnutrition is a negative prognostic factor for survival in ALS patients. And for several different reasons, and a lot of them I'll go over today. But the bottom line is that you want to make sure you're getting all the nutrients and the fuel that you can get. If you don't put enough fuel in your car, it's not going to run well, and the same with our bodies. So some of the primary concerns related to ALS and nutrition. Obviously, adequate nutrition intake to prevent malnourishment and premature lean body mass loss. Anytime we lose weight, whether it's voluntarily or involuntarily, we're always losing some portion of muscle mass. And a lot of us tend to think of muscle mass as skeletal muscle mass, as far as weight loss goes. While that's true, and that does lead to weaker muscles, if you do lose some, we also, especially in this population, when things like forced vital capacity and respiratory measurements are so important, you're losing lean body mass in your skeletal muscles, but you're also losing muscle strength in your diaphragm. Your diaphragm's a muscle as well. So, I try to get people to think of the bigger picture when I talk about lean body mass loss. It's not just, the ability to pick up something or pick up a fork or move something, but it's also the ability to breathe. It has an effect on, a lot of different areas. Reducing the risk of respiratory complications, that goes right into that. And, you want to maintain the lean body mass that you have for as long as you possibly can, because that strength is what's obviously very important for quality of life and for being able to, take care of tasks that we a lot of times take for granted. And then, of course, maintaining oral feedings for socialization and pleasure as long as you possibly can. That's a huge quality of life factor too. But there is a stipulation that you want to maintain your oral feedings for as long as it's safe. You don't want to push anything or force anything, and if you feel like you have to, and you're tired of that and you're frustrated because of that, then there are other options as well, and namely the PEG, and I'll be going over that with you guys today too. So the effects of malnutrition, we can just begin in our minds to think about some common sense effects. Obviously, muscle weakness, general fatigue, cognitive decline, all of these things, and what a lot of these studies find is that the vast majority of ALS patients, when they actually calculate their nutrition intake, the majority of them are below the recommended daily allowance or average or numbers. So vast majority of people aren't taking enough nutrition. We know that as a fact. And then also BMI, we look at body mass index too, and that is. Anytime that's going down, namely 20 or under, there are going to be greater risks of malnourishment and weakness and other complications that can arise from that. So the bottom line here is all these studies, what they're showing is that you want to avoid unintentional weight loss. You want to stabilize weight as much as you can, and you want to prevent that loss of lean body mass. So this is a very, very, very common question I get, and it's a very understandable question. What is the best diet? What should I be doing? And there's certainly a lot of information on the line that could give you a certain diet, a lot of misinformation. But the bottom line is that you want to have a diet that's still varied in nutritional intake. I still want people to get their fruits and vegetables and their whole grains and their lean meats and adequate water and all that kind of stuff. At the same time, I really want them to, at the very least, maintain their weight. If they are low on the weight scale, then I'll increase their weight, and that's essentially the bottom line. So while I want a generally healthy diet, I also want enough calories to maintain weight. And then BMI goals on the bottom there. So there is a pretty well-known study, and BMI has been studied a couple of times in relation to ALS and survival, and what they found is that the optimal body mass index ranges are between 30 and 35, and then 25 and 29. 25 and 29 you're actually considered overweight. 30 and 35 you're actually considered, obese. And people are surprised by that, and there are a couple of possible reasons for that. ALS is a very demanding disease, as a lot of you know. As time goes on, things get more difficult. Breathing becomes more difficult, or may at least, and weakness increases and stuff like that. And because of all these things that are going on, and even at a cellular level, mitochondrial level, there are possible changes and dysfunction that are happening that increase our risk of losing weight. And so the general idea is that if you have a higher BMI, you have kind of more energy reserves to sustain the disease for a longer period of time. So as far as the types of nutrients go, I also get questions about, well, should I be taking a ton of protein or carbs, or should I just be loading up on fat, things like that. The bottom line is that, again, you want enough calories to maintain your weight, but at the same time, a lot of people don't know these numbers in particular. These are very standard numbers, and if you take a gram of fat, take a gram of carbohydrate, and take a gram of protein, and compare how many calories are in each of those. Carbohydrate and protein, you're both going to get 4 calories per gram. Fat, on the other hand, you're going to get 9. So you're getting a much bigger bang for your buck. You're getting over twice the amount of calories per gram of fat that you do the other ones. That's not to say that you should load up on fat necessarily. There are some GI issues that could happen because of that, but you want to incorporate everything, but you also want to use things like butter and oils and whole milk and things where you'll get a higher fat content, because that's generally the easiest way to increase calories to the best of your ability. There are so many nutritional supplements now. There's 6 up here out of probably 6,000. I'll go over a couple of these, but the big one with a couple of these is that they're so concentrated. A lot of our people with ALS, they tend to experience early satiety, and basically they get full quicker, in their meals. Did anyone here ever experience that during their course? They get full pretty quickly, yeah. So what we try to do is make sure, they're getting their calories, but they can't take in these huge meals or taking a lot of liquid, because it's going to fill them up and they simply can't tolerate it. So something like the Benacalorie, which is on the top right corner there, that is a little disc. It's like that big. It's filled with a semi-solid liquid, and the vast majority of it is compromised of fat, but in a very small amount of volume, there's 330 calories, and I think it's 7 grams of protein, and that's really packs a punch as far as calories go. So if we have some individuals who can only handle 4 cans of formula, for instance, each day because of the volume, then we'll add on a Benacalorie, and they'll just put down through the tube too, and that can help them get basically another can of formula without having to add another 240, 250 milliliters. Things that taste better, Carnation Instant Breakfast rather. They have ready-to-drink shakes and then packets that you can mix in with whole milk, and that can really pack a caloric punch. Boost, on the top left, it's called Boost BHC, and you can't find this in stores very often. I don't know why, I guess it's more of a specialty line, but you can certainly find it online in Amazon as well. You'll probably get better prices if you search. And there are, in that one container, it's just a regular juice box size, there are 530 calories and I think 22 grams of protein. So even if a person can handle 2 of those a day, they're getting over 1,000 calories, and for the majority of people are probably getting the majority of their protein needs as well, and just that. So very highly concentrated items are on the market, and can make it very easy for someone who can't tolerate a lot of food. Beneprotein, protein powder mix, that's another one. If someone's worried they're not getting enough protein powder, that's always a go-to. You do want to be wary of going into GNC and then having them sell you some, anabolic steroid-induced whey protein powder made from, who knows what. But 100% whey protein, something like that, can certainly be beneficial if a person's unable to get it in their, typical diet. Scandy shake mix. Scandy shakes is spelled S-C-A-N-D-I and shake mix. It's a very, very, very high calorie drink mix that you can add to whole milk and make it even higher in calories. And that's similar to Carnation Instant Breakfast, but even higher in calories. So that's something that you can search for online too and definitely use. And then of course, Ensure, Boost. I always recommend patients opt for the Boost Plus or the Ensure Plus versions. Boost and Ensure are both basically the same thing, they're just made by different companies. So if you've ever wondered, they're just equivalents made by different manufacturers, that's all. But I always tell people to opt for the Plus versions because you're going to get more bang for your buck and more calories and stuff like that. In a good chunk of our patients, what we also find is that some are hypermetabolic. And do you guys understand what hypermetabolic means? I'm sure a lot of you do, but some very likely don't. So hypermetabolism, all that means is that if you ever knew that person when you were growing up and that person weighed like you, where you could eat a cow and not gain an ounce. Your body, for whatever it is very efficient at burning those calories. And what we find is that some of our patients at our clinic, when we do the metabolic testing, which is shown here, and you wear that mask and you breathe through the mask, it's the most boring and easiest test you'll ever experience in your life. You breathe in that mask for 20 minutes. It tells you what your resting energy expenditure is. And what that is, the amount of calories that you burn at rest, not including calories burned through physical activity or anything else. But what we find is that if the calorie burn is 110% or greater than what was predicted initially based on your height, weight, age, all that kind of stuff, then a person is labeled hypermetabolic, and it just means they have a high metabolism. Now you can imagine someone that has a high metabolism is going to wake up and they're already going to be in a little bit of a calorie deficit, and they have to kind of catch up with their metabolism. They have to eat a little more to be able to adequately sustain their weight and their lean body mass. So, anytime a person ends up being hypermetabolic, when we measure them, and it can change over time too, we always want to follow them just a little more closely and make sure that their hypermetabolism isn't affecting their ability to maintain their weight. We look for involuntary weight loss and things like that. So definitely an area of consideration for all of our patients. And of course, hydration. I cannot stress this enough, and Velma, I'm a great advocate of this as well. Water, there's a reason our bodies are made up of the majority of water, and that's because it is involved in so many processes and metabolism. And we know that if we're dehydrated, our cognitive function isn't as good, our muscle function isn't as good. They always tell athletes and people in general that if you are thirsty and you have that thirst sensation in your mouth, you're already a couple % dehydrated. And for an athlete, that may end up being a few minutes in a race. For anyone else, and for our clinic, patients in particular, it could mean a certain amount of percentage of muscle strength lost and stuff like that. And that's a really easy way to gain the strength back and make sure your body's functioning at optimal level. It's just like putting the oil in an engine. It just helps everything run smoother. That's the best way to put it. So I always stress adequate water intake during the day. And if a person doesn't like water and they don't like the taste, which is completely understandable, then I tell them to mix it, dilute some juice with it, and you can get some extra water that way, and get some sweetness. Or I tell them to add some fruit to it, and you can kind of, infusing water is a big thing now. And you have these water bottles where you can add fruit to it, and then put it into a full water bottle filled with water, and then over time the fruit kind of bleeds into the water, and you can get a better taste for it. So there are a lot of different ways of boosting the taste of water if you don't like the taste, but I can't stress enough the importance of hydration. So what if you have issues treating swallowing? Some people have no issues whatsoever. Their symptoms are limited to their extremities, and others, if they have bulbar issues initially or at some point during the progression, they're going to have issues chewing and swallowing. So so what do you do? There are a couple of different things, and obviously, to know whether you are having issues, most people wouldn't know it, but some people might not. They might be very subtle changes over a long period of time that they don't fully recognize as dysphagia. So chewing and swallowing, difficulty, obviously loss of tongue control, that's a big one too. Some individuals may lose some strength in their tongue might atrophy to an extent, and they can't move the food around their mouth as well as they need to and get it prepared to go back into the back of their throat and then to swallow. So a result of that is then pocketing foods, and food becomes stuck in different areas, and a lot of people have said they have to manually move food in their mouth to get it stuck from where, in their gums or the roof of their mouth or something like that, and that makes it even more difficult. Difficulty initiating swallowing. I have had individuals tell me that one of their issues that they're having is they have to swallow more in stages now. We take for granted swallowing a lot of the time, but the reality of swallowing is that every time you swallow, there are about 50 pairs of muscles and then also nerves that are involved and that have to work perfectly in order for you to swallow. And if it's just like a link in a chain. If even one of those is off, that's going to cause a cascade effect, and everything else is going to be thrown off, and you might cough, you might choke, whatever might happen. So it's very easy for us to realize that it doesn't take a lot for us to have significant issues swallowing if even one of those muscles are messed up. Coughing or choking on meals or meds, medication in particular. A lot of these pills are difficult for anybody to swallow, let alone someone who's at risk for swallowing difficulty to begin with. And so we certainly recommend anything that can be crushed for individuals to get a pill crusher and crush it up to a pulp and mix it with water and then take it that way, or they could crush it up and mix it with like applesauce or mashed potatoes, something like that. Things that aren't crushable, gel tabs for obvious reasons, and then also extended release medications. You don't want to crush those up for obvious reasons, but they also have a very hard coating on them that make it very difficult to crush. So if you try, good luck. It won't be easy, but you obviously don't want to anyway. If they are extended release and you can't take them, then pharmacist is the best person to talk to regarding changing the formulation to a more suitable one. And then I have had individuals tell me that if they have a gel capsule, they will puncture the capsule and empty the contents in water and swallow it that way. It's not always a guarantee that you're going to get everything that was in that capsule, because what people sometimes find is that whatever that was in that gel capsule tends to infuse in the shell itself a little bit. So you may lose a little bit as far as volume goes of that pill, but I have also had people say that they drop a gel capsule in a glass of warm water and let it dissolve over time, and then they will take that or pour it down their feeding tube, and that's their way of doing it too. Again, food sticking to the throat, drooling, if the person is drooling or they have more saliva producing, they can't handle it, that may be an indication that they're having, some bulbar effects, and we want to make sure they're staying on top of that. A change in dietary habits, if you find that meal times are longer, and you get frustrated and you don't end up finishing your meals, obviously that's a problem too, because if you're not finishing your meals, you're not getting the calories that you need. So all these different things play into possible signs and symptoms of choking and swallowing difficulty in this stage. Consistency problems. One person may not be able to handle thin liquids, another person may not be able to handle particulate foods, and what I mean by that is crumbly foods, things that have a lot of different pieces to it. Rice could be one, a dry crumbly cookie could be another. Stringy foods like cooked spinach, if you kind of, whenever you saute it in the pan, it kind of gets kind of stringy and thins out. Melted cheese, I myself have choked on melted cheese in the past because it gets stuck in your throat, but then it stretches and become very difficult to handle. Mechanically intensive foods, tough meats. I always recommend slow cooking meats. Use the crock pot; that is your best friend. Fish in particular are very soft too and easy to handle. And then also pills, like I touched base on before. So treatment intervention. So what do? Avoid mixed consistency foods. So a lot of soups, if they have a very thin broth in them, but then they have chunks of potato or meat or something else in there, it can be very difficult for a person to handle both a thin liquid and a solid at the same time. So we try to steer people away from those types of recipes and stick to something that's more consistent, like a casserole, or anything that's softer and doesn't have different consistencies mixed throughout it. Modifying utensils, Amber is the guru as far as this goes as well, and she can certainly help with that if you have any issues with the actual act of getting the food from the plate to your mouth. Nutritional supplements, of course, making sure that if the person is having difficulty and it's leading to a decrease in their oral intake, that we look at other nutritional supplements or other types of foods that can pack a real punch so they're not missing the calories even if their volume goes down. And then head positioning as well. Making sure you're not, hunched over, making sure you're not, laying back too much. But one of the very common things that we recommend is something called the chin tuck. And Amy may have spoken to many of you about this. Some of you may have not heard of it, but all you simply do is tuck your chin down. It helps close off the airway just a little bit, but be a great gravity, when you try to swallow something, it also helps it to go in the right spot down the esophagus. So all you do is before you swallow, tuck your chin down and then swallow, and that can help a lot of people. Simply paying attention to, like I said before, we take for granted a lot of times the fact that, we swallow, without effort. And for anybody that's having any difficulty, you want to make sure that you're sitting down at your meal, focusing on the task at hand. You don't have the TV on, you're not kind of looking at that or laughing or talking to someone. Just sit down and focus, and a lot of times that can be an easy way of helping them as well. Take small bites on the top left. For obvious reasons, you don't want to take too much that you can't handle at one time, or that leads to increased risk of choking and aspiration, all those kind of things. There are a lot of products out there. Resource Thicken Up, Simply Thick. So these are a couple. This is called Jumex. So this is a nectar thickened apple juice. It's naturally thick. Or rather, they make it thick, but it's thick already. You don't have to prepare anything. So that's a possibility. Thickeners like this, Simply Thick is one. This is a gel that you mix with thin liquids, and it can just change the whole consistency of a glass of water, for instance, and make it much easier for somebody to swallow. The gel consistency isn't as popular as there's another version. The Resource Thicken Up is a powder. That tends to make the liquid a little more consistent, so a lot of individuals prefer the powder over the gels. But there are plenty of options out there and plenty of ways to be able to get your fluids without having to choke them. I think Nestle also makes like a thickened coffee powder too. So if you really want your coffee, you don't want to add something like this or anything else to it, you can already purchase coffee that's pre-thickened. Not changing. Did I press something wrong? It says it's changing on here, but it's not a. Yeah, it's not working. The number's changing on here, but it's obviously not changing on the slides. Do you want to just manually change it back there? Yeah, there we go. I'm changing it. I'm still going. I can still press it. It seems to be working. In case any of you wanted a refresher from this morning. There we go. All right, back in business. And dysphagia cups. Has anyone, any of you ever heard of a dysphagia cup? Do you know what I'm talking about? So it is a cup looks like a normal cup, except it's cut out on one area. And the reason being is so you can take a drink without having to lift your head back and then possibly lead to any liquids going in the back of the throat. What you can do is just do this, and then you can just lift the cup off, and it will come all the way up, and you don't have to tilt your head back. Essentially, is what the so, very simple thing, but a very useful thing for a lot of people.
Where do you get those?
That's a good question.
Okay.
You can certainly find them online, and I don't know, Mindy, do you know any retailers?
I don't off the top of my head, I know Amy does.
Amy, yeah, I mean, Amy can certainly find them too, yeah. I'm sure they're very easy to find. We can put us to work and we'll find them for you. And then, obviously modifying foods, for safer swallowing as well too. I have a book here, and it's called the Dysphagia Cookbook, and I have a couple of copies in my office if anyone wants one. But it has a lot of good consistency diet plans in here and menus for someone who does have difficulty, chewing or swallowing, and they need some solid, soft consistency, menu ideas. There's some. We might have a favorite meal, but we don't necessarily know how to modify it in a way that will make it better for someone that does have some difficulty. So this is certainly available for anyone that might be interested. So you've tried these swallowing techniques. You've done everything you can to handle as much as you possibly can. You're still losing weight. You're getting weaker. You just get frustrated at meal times. Because you get frustrated, you don't end up finishing your meals. You don't get the calories and nutrition that you need. So what's next? What other options are out there? One of those options is the feeding tube or PEG tube. PEG tube stands for percutaneous endoscopic gastrostomy tube, or a G tube. It's a tube that's inserted directly in the stomach when for whatever reason the person cannot maintain adequate nutrition by mouth. The bottom line of one of the bottom lines, at least with the PEG tube, is that there is a huge negative stigma towards it. It is viewed as an end-of-life thing. It's viewed as just kind of a weird thing, and it is a little different. You have a tube in your stomach, but at the same time, if it's helping you, maintain your nutrition, it's obviously a very important thing. If I had one, if I had a PEG, you would have no idea right now. Unless I'm running around this building naked, you have no idea that I have one. It's because it's wrapped and taped to your stomach, and I'll show you. So this is what one essentially looks like, at least the initial ones that they place. This is a little longer than normal, maybe a little bit shorter, but the only thing that's inside of you is that. That's the only thing. It's a rubber bumper on the inside of your stomach. A lot of people picture, an NG tube or an OG tube that are, going down your nose or your mouth. It's not that kind of tube. It's a completely different location. So that's the only thing that's inside of you, okay? And then externally, you would obviously see this, and it would just be wrapped up, taped to the abdomen there. You could close over it. That's it. There are no restrictions at all with physical activity or anything like that. I tell people, go skydiving for all I care. It doesn't matter to me. Just because you have it doesn't mean you're going to be confined to a chair or anything like that. It's simply not an end-of-life thing whatsoever. A lot of our patients have them for years and years and years, and some do now and have had them for years. Here today. So there are no restrictions with it. The site, once it's healed up on your stomach, after about a month or so, the site can be submerged underwater, so you can do, pool therapy or jump into a pool and experience that still. So like I said, the bottom line is there are no restrictions as far as that stuff goes. So when does a person need a feeding tube? We look at the big picture. Do they have dysphagia and coughing and chewing and swallowing difficulty? If they do, is it leading to involuntary weight loss? Are they getting weaker? We look at, if they have extended meal times because of that, dysphagia, and they're getting frustrated again and not finishing their meals. Do they have anxiety about eating? I have had individuals tell me they don't want to eat, and they have sometimes refused feedings because they're too anxious that they're going to, and too nervous that they're going to choke on something, so they don't end up getting the stuff that they need, at the end of the day. Pills, if someone has too much trouble with pills, they can't get the proper medication or supplements. also declining respiratory status. One of the big tests that we do is the forced vital capacity test that Velma does on an enormous amount of our patients. And what it does is, it tests respiratory strength, breathing out as forcefully as you can and breathing in as forcefully as you can. And when those numbers get to around 50 or 60%, if a person's ever considering a feeding tube, we always recommend it around that time, because under 50, studies show there are just more risks associated with the surgery of placing it itself. Then also the lower it goes, it tends to be that the individual with ALS is more progressed too. And outcomes are simply better the earlier that you place it, because the body's in a better condition to handle the surgery, and also because the person, tends to not be as malnourished as they might be later on in the course of the disease. So, the earlier the better. We always say, if a person's ever considering one. If a person doesn't want one, as long as I provide the proper education and they know, the feeding tube like the back of their hand, then, I'm comfortable with them, not using it. That's completely their choice. Certainly don't want to force anybody to do anything they don't want. But at the same time, like I said, there is a big negative stigma towards it as an end-of-life device, as a, physical activity restrictive device, and I try to squash those as best as I can. That's why I like talking about the PEG so much. Anytime I talk about it, I frankly get excited, because a lot of individuals are surprised by the general ease of getting one and maintaining it and taking care of it and stuff like that. Then obviously, one other risk too is silent aspiration. Silent aspiration is basically something, food or liquid going down into your lungs without you knowing. It might be a little bit, but because of a person's gag reflex being diminished, they may not know that, and that can lead to stuff like aspiration pneumonia and nasty things that can certainly be avoidable. So as far as survival, I will never tout the PEG as it's something that will increase survival. Studies have shown that it can increase survival anywhere from 3 to 8 months, but it depends on the person. However, it's a big quality of life factor too. My bottom line, my job is to make sure no individuals ever become malnourished, and this is simply a way of preventing that in patients that can't get enough by mouth. This is basically to show that there have been a ton of studies on survival with gastrostomy tubes in ALS patients, and the fact of the matter is there are a lot of reasons why it may or may not work in one person. An individual may simply not be compliant. It might depend on the onset, the type, whether it's limb onset, bulbar, or mixed. It might depend on the age of the person, that diagnosis, and a lot of different factors. So I don't like to give a certain number and say, oh well, if you get this, you will survive another X amount of months. I tend to approach it from the standpoint of, well, it's going to prevent malnutrition, and if you're malnourished, you're going to be weaker, and things can progress certainly faster than they need to, compared to if you were getting adequate nutrition, and that's really the bottom line as far as this goes. So quality of life increases, risk of malnutrition decreases, and obviously two very good reasons to at least consider this intervention. This is a very typical reaction to getting the feeding tube as far as body mass index goes. A person may have, before they get the feeding tube, a long decline or a steep decline of their weight, and lead to weakness and everything like that. Then once they get the PEG, they will recover at least to an extent. As long as you get enough calories in someone and they can tolerate it, you can generally pack on, several pounds after they get the feeding tube. And so basically this is kind of the general way things tend to follow. We've had some individuals get back to a weight they hadn't been at, in 20 years, and we have other patients that, they had a little more trouble for whatever reason, but they still were able to, at the very least, cease the weight loss that they were experiencing and be able to recover. And 10-pound weight gain, for a person that was, 10 pounds underweight can mean a vast difference as far as cognitive function and general well-being and everything like that. Certainly can be very, very beneficial. How many people get feeding tubes? Well, our clinic, this is a chart of the past several years. So this year we're actually on track to destroy the previous years for whatever reason. In, let's see, 09 and 010, they're averaging anywhere from 15 to 25. 11 in 2012, we hit some high marks of in the mid-30s patients per year getting the feeding tube, and there may have been one or two that we missed, but I assume we never tried to. And then this year, you can see the line all the way on the left side. That's this year, and we're only at April now, and by the end of next week, we will have 19 individuals get a feeding tube this year already, compared to last year's total, I believe it was 16. So we've already surpassed last year's total just by April this year. Whether it's just a matter of some people being stubborn and they finally come around to it, or just chance that others, came to our clinic and ended up needing it. It just depends. But there's certainly a lot of our patients end up getting it at some point, and then they do benefit. And I hope that the people here, can attest to the fact that it has helped them out at least somewhat, since they haven't gotten it. Obviously still patients hesitate, and like I said, as long as you're properly educated, that's fine with me. But the stigma of it being a terminal stage device, of some embarrassment a person may feel because they're just not familiar with it, it seeming weird, and the tube sticking out of their stomach, the thought that it might limit any activities, or change in the family dynamics and stuff like that, When you get a feeding tube and you use the tube, it becomes routine like anything else. We have a lot of individuals that still eat by mouth because there are a lot of foods they can still safely eat by mouth. It just wasn't in a volume that they could maintain their weight adequately, so then they got the feeding tube, and then they were able to kind of do a tag team approach of putting formula down the tube and then continuing to eat by mouth. And that's the way that they maintain their weight. You have other individuals that get it and they'll look at it just as a more of a proactive measure because they're anticipating future issues by mouth, and so they'll get it and they may just use water down, or if they have any pills they have trouble with, they'll just put that down until they need it for nutrition in the future. And then we have other individuals, obviously more progressed, that may need it to meet 100% of their nutritional needs, but if they didn't have it, they wouldn't be able to eat, period. So a lot of people think that you can't eat by mouth if you get one, and that is 100% false. The only limitations you have eating by mouth after you get a feeding tube are what were already there before you got it. Whatever foods that you couldn't handle, obviously you still can't handle after you get it. But at least the pressure is off. The pressure is off the patient. The pressure is off the caregiver of having to force themselves to eat during the day. The meal times are decreased. They can spend more time with their family doing other things than having to sit down at the table for 2 hours and try to get all the nutrition. And then show up for clinic and still have a 10-pound weight loss. So the main thing we try to do is just educate. The vast majority of patients are very appreciative that I bring it up in the first visit. Others not so much, but I will always feel better if I can at least plant that seed and give that education, or whether a person wants it or not, because of the negative stigmas that are associated with it, and the fact that it isn't as a crazy thing as people might think it is. So what you should remember, obviously, like I said, it's not an end-of-life measure. There's no restriction on physical activity. Easy maintenance. The main issue with the tube is you don't want it to clog up, obviously, for obvious reasons. But as long as you're not putting, chunky chicken noodle soup down it and full pills, or whatever else, then you typically should, be perfectly fine with it. And yes, you can still eat by mouth if whatever you're eating by mouth is safe and you can safely swallow it. And like I tell most people, just consider it like another esophagus that doesn't choke. That's all. So there's no difference with metabolism when you put something down. It goes right into your stomach, just like if you swallow it by mouth. The only difference is it's bypassing your esophagus first, so there's not that risk of choking and aspiration and things like that. They never underestimate the little creativity. So it might be hard to see, but they're not putting water down the tube there. So you can imagine what that might be. But it's not apple juice either. But yeah, there are multiple ways that you can use the tube. I don't recommend this, but whatever you do in your own time, So the bottom line of nutrition is, calories, calories, calories. Making sure you're getting enough to maintain your weight, to maintain that lean body mass, and feel better, and maintain or improve your quality of life. Maintain consistency of foods. If you are having any difficulty in utilizing texture modification and dysphagia recommendations and chin tuck and eating slowly and all those types of things. And then, for a lot of people, their appetite tends to decrease too. And for whatever reason, whether it's a medication or whether it's, early satiety or, whatever it is, they just don't want to eat. And, what I tell them is, as much as that stinks that you don't enjoy the food that you used to, you have to try to change your focus towards food as less of a pleasure and a luxury and more as a medicine. We think about all these pills that are maybe taken during the day, and you don't want to take them, but you have to, and you should. And you should take them at certain times during the day. And I tell people to think about food the same way. You may not want to eat at a particular time, but your body still needs it, and you should eat at certain intervals during the day. So, as much as a person can change their attitude towards it as less of a luxury and more as a medicine, the easier it is to establish a routine and stick to it. Then also, of course, it's important to read out the misinformation, online. A great source of information is PubMed.com. That's where you're going to get a lot of studies and a lot of scientifically backed information. There's a lot of information online that's very anecdotal and simply not scientifically backed whatsoever that people can fall into a trap in and end up spending, a ton of money on supplements or a ton of money on whatever else, and possibly putting themselves at risk or just simply wasting a lot of money. So it's really important that you look to us for our clinic for proper recommendations, but also take everything with a grain of salt that you find on the computer. And what I always tell people is that you can't control the fact that you have ALS. Obviously, you just can't. But one of the things you do have control over is what you put in your mouth, how much of it that you consume. You can always have have control over your nutrition, even if you have control over nothing else. So take advantage while you can and be proactive about things. And if you have any issues, even the slightest issues that you wouldn't even think of bringing up at clinic, bring it up, and just so we can at least document it and make sure that we're staying on top of things as much as possible. At the very least, when you do come into my office, you can have your cake and you can eat it too, including the fruits and vegetables and all those things. That is it for me. Are there any questions? Anybody go over anything? Are there any questions at all regarding nutrition? Yeah.
In the instance of going with the higher body mass, are you not raising the risk of other health issues?
Exactly. So that's a very good point. And I meant to mention that. So BMI of 30 to 35 has been shown optimal for survival. Above that, the benefits decrease. There are certainly more risks and more issues with mobility, pressure sores and things of that nature that become difficult to take care of. So yeah, you don't want to go too high. It's not the more is better type of thing. There are certainly limitations to that, to that line of thinking. But yeah, as long as you have packed on a couple extra pounds, I will not be mad at you whatsoever.
Can you talk about rather than doing the bolus feedings, the pump?
Yes, for sure. So, if a person can't tolerate a lot of volume by mouth and not getting a feeding tube, they very well may not be able to tolerate a bolus feeding, which is the typical way of administering the feedings themselves. So basically, there are a lot of options with feeding and with feeding through a feeding tube. There's the bolus method, which is putting stuff in the syringe and then using the syringe as a funnel stick on the end of the feeding tube, and then pouring stuff down and letting it go into your stomach. Some people simply can't tolerate that amount of volume at once, even so. So there are other options as well, including a gravity bag, which is basically like an IV bag filled with formula. It can slowly, via gravity, go down the tube, attached to the end of your feeding tube, and down into your stomach. And then there are also electric pumps that you have a big bag of formula set up and with an electric pump attached to it, and that can go at any rate that you want it, as low as you want it, whether it's 20 milliliters an hour or if you want 150 milliliters an hour of formula. That can be adjusted for whatever a person tolerates, and that can run 24 hours straight through the day. You could split it up in a couple hours during the day or a couple hours at night. The possibilities are endless to fit a person's schedule. Just because you have them doesn't mean it's going to take the whole day to do a feeding or anything like that, unless you want it to. But one, there are issues with tolerability and things of that nature, and GI issues especially. You want to do whatever you can to make sure the person is getting all the formula that they were prescribed, and so there are a lot of different methods and ways of doing that when you do have a feeding tube. 9 times out of 10 there is some sort of backup plan, and we've certainly hit a lot of those over the years, and you know, vast majority of them do work. So you know, it's not just one way of feeding your feed tube. There are several different possibilities, and whatever works for one person, you know, we'll figure it out basically. Any other questions?
On the BMI, you had 30 to 35, and then you had 25 to 29.
Yep, so 30 to 35 was shown to have the longest survival in a particular study, and then 25 to 29 was the second on down, second best, I guess you could say. So anywhere from 25 to 35, you know, we always say is ideal. If you go under 25, then you're losing the risk of, or you're approaching the risk of, you know, too little lean body mass and losing strength and things of that nature. If you're going above 35, you know, as you had mentioned, there are diminishing returns and increased risk of other complications like pressure sores and mobility issues and stuff like that.
At the clinic, y'all do a BMI?
Anytime a person comes in and they get weighed, we get an automatic updated BMI. Body mass index, all it incorporates is your height and your weight. So as long as you have those two measurements, you can calculate a BMI in 2 seconds if it doesn't show up on the computer. So we're always tracking that.